We'll open the floor to discussion. While that's getting sorted, I'm going to bring up a question for Robert. With the phenotypic data, which population of patients are you looking at, and have you looked across the different phases to see if the 27 PD-1 expression changes?
Yes. Primarily, we looked in the patients, the long-term non-progressors with rather low viral load, but we also looked in a few patients with high viral load. So there's a little bit more exhaustion, but it's still different to HCV. So it's still not as an exhausted population than you expect in hepatitis C, even in patients with really millions of viral DNA detectable. So there seems to be a general difference between HBV and HCV, and I think, coming to the questions, I mean, is it why do these cells look like, despite the fact that you would expect that lots of antigen is still present? We do know that hepatocytes are positive. So either maybe class 1 is downregulated, or maybe the antigen is masked by antibodies or something. I think these are questions we have to try to find out now.
Go ahead, Georg, with your question.
I have a lot, but let's start with Robert, since you're there. You showed the idea that maybe one needs to have different strategies to resurrect T cells targeting different of the proteins. Have you thought about, are there certain proteins you want to have responses to more than others? I mean, that's a big question in the HIV field. And so one wonders, do we really want them all, or is it maybe the HBS ones that the acute resolvings have and the chronics don't that we need to preferentially target, or any ideas to that?
I mean, I think the one thing we know is that S antigen, of course, is detectable during acute infection and is associated with clearance. S antigen is present after clearance, CD8 T cell responses, but they're specifically lost in chronic infection. I think that's the strongest association. I think, you have some data you could talk about on CoA polymerase differences already early on in the acute infection. I don't think that we have data yet in comparison to what is known in HIV, whether it's more harmful or an advantage or disadvantage if a certain antigen is more strongly detected or targeted during acute versus chronic infection.
Because with the big differences we see, I think it might be quite possible, that we want to have the response focused on a certain area, while they might be the most effective.
I agree with that, and I think that polymerase is an interesting target. It's present here during replication, but with all molecular biologists I talked, and in our department, Michael Nassau, for example, is present. Everybody tells me he would expect more core on the surface compared to polymerase. So why do these polymerase-specific CD8 T cells look so much more exhausted, activated? I think it's really an interesting open question that we need to find out.
Okay, and if I can have another one right away to Daniel. Actually, two. One is, will you try the PD-1 approach just with a couple of more doses? Because obviously, for example, the saturation of PD-L1 is measured, I think, in the periphery. We don't know what's happening in the liver. So it might be still good, since it's so safe, to see a couple of doses. And the second question is, the cells you expanded in vitro against the tumors, you showed phenotype. Are they actually also functionally better?
Maybe to the first question.
No, it was for Daniel, actually. Sorry.
Oh, PD-1.
Yeah.
Regarding the doses, absolutely, that was the first thing that I said post-study as well. I think what was interesting there was to accurately define an occupancy window. I think to dose again effectively every 40 days and to maintain that blockade for as long as possible would definitely be advantageous. I think in terms of the accumulation or the penetration of the Nivo into the tissue, I'd have genuine concerns with dosing at such a low level in a tumour setting, just because of the poor vascularization of the solid tumour, the difficulty of accumulating a monoclonal in that setting. In a relatively non-fibrotic liver, I think it's probably reasonable to expect that the serum concentration of antibody is at least reasonably reflective of the concentration that might be building up in the liver, just simply because of the difference in the tissue. In a fibrotic liver or a cirrhotic one, then I think absolutely you would probably want to dose more frequently and higher. With regard to, I apologise, the second question, I forgot. Oh, the expanded cells. We're only partway through that study, and I really only included that just as an example of how the particular cytokine regimen could alter PD-1 expression in a relatively uniform manner there. And interestingly, I think that that comes back to the point that Adam made, which is that as cells are proliferating, that's when you have a window for altering their phenotype. And one of the sort of resources that I work a lot with in a hands-on sense in the lab is antigen-specific T-cell clones. Quite often, effector or effector memory T-cell clones that we isolate against viral antigens, EBV antigens, for instance, will be PD-1 positive. After re-expansion, they'll be PD-1 negative using with the cytokine cocktails that we use, and so that's a nice case where we know there's absolutely no loss of a particular subset of cells, which is always a problem in a heterogeneous mix. But because it's a T-cell clone that's giving rise to its own progeny, we know there's no loss there, and so we can demonstrably modulate PD-1 expression outside the body. What happens when those cells will go back in is to be determined, and we're looking at developing a mouse model to assess that.
In the meantime, so I have a question for the industry colleagues up here working, I guess, particularly on the orally delivered innate immunomodulators, because there's one of the buzzwords that, you're giving a drug that goes through the gut. Somehow you guys, all of you got away without mentioning the microbiome once and how this might actually modulate your responses to the drug or modulate toxicity to the drug. I mean, is this something that you're looking at, you're considering? Are you thinking about modulating it to actually improve efficacy? Because it seems like it's a very important topic to be covering. Does anybody want to comment? Simon, you look like you want the microphone.
Yeah, no, I agree. I think it's a fascinating area. Clearly, there's a lot of proof of concept already from the PD-1 field related to anti-tumor efficacy in that regard. But yeah, clearly, whether the microbiome can be affected by the drug, whether the microbiome then alters the efficacy of the drug as well. And that's something we'll be looking at in our phase 2 studies.
And do you think most of the activity of this drug is coming from the gut and then just draining cytokines to the liver? I mean, that's what I'm trying to understand.
I think it's
cells trafficking.
I think it's different for different drugs. Inirigavir is a prodrug, so it's taken up as the prodrug, converted and gone from serum in 10 minutes when we radio label it and do the PK. And the two active metabolites are concentrated in the liver very, very quickly and with a high penetrance into hepatocytes. So I think that most of the activity that we see is hepatocyte specific. We haven't seen any off-target effects on immune anything so far. But I think the TLR7s and the TLR8s have some gut stimulatory activity.
Yeah, for our TLR7 agonist, so actually it's a double prodrug. It can only be activated in the liver. So it basically bypasses the gut activation.
Yeah, please, Mark.
Actually, Daniel. There's been nice work showing that the expression of CD28 is very important for T cells to respond to PD-1 blockade. So I wondered if in that patient you had the best response to PD-1 blockade. Have you been able to go back and phenotype their starting HBV-specific T cells and see whether they had higher CD28, for example?
I haven't assessed the only assessment that we did in terms of the HBV-specific T cells was ex vivo ELISpot. We don't currently have access to a tetramer, although you could certainly get some of those. No, sorry, I mean simply for the purposes of that trial, we didn't investigate. And off the top of my head, these patients weren't haplotypes coming in, so I'd have to double check if they're A2 positive or not. But absolutely, it was really interesting that through the course of that study, the maximal ex vivo ELISpot response, and this is not from expanded cells, this is just simply cells that were circulating in the periphery, there was no correlation between maximal spot number and surface antigen decline. So definitely I think it speaks to the function of the cells being more important than their frequency. I certainly agree with that, especially given the effects that PD-1 has on co-stimulatory signaling.